You want to know something about infective endocarditis. I know you do. Because forget the GTC, forget the BDDA, forget the CQC, forget the Defense Union. Just concentrate on Mrs. Horn. Because you want to know something about infective endocarditis. And then, you want to know something about the symptoms. You want to know something about the physical signs. What you would see in patients with infective endocarditis. And why? Because if you could see all this, you want to diagnose it. And so you want to diagnose the sickness. And having diagnosed it, you want to treat this quick. So I want to talk to you about the treatment of patients with infective endocarditis. Because if you don't diagnose it and you don't treat them quickly, they will die. And then I want to talk to you about the prophylactic treatment in light of the NICE guidelines of 2008. And finally, I'm going to talk to you about the rarer organisms other than bacteria which can cause this illness. So the first thing you see up there is called infective endocarditis. And I know you know everything about infective endocarditis, but I'm still going to tell you. We are concerned with the infection of the endocardium. So if you took a section through the left ventricle, we have the pericardium on the outside, a double layer sac covering the heart. In the middle, we have the myocardium, specialized cardiac muscle cells, the engine. And on the inside, we have the endocardium, smooth, glistening layer, very thin, covering all the cavities of the heart and reflecting herself over the valves. So when we talk about valvular disease of the heart, we're talking about the disease of the endocardium. And so infective endocarditis is a condition in which infective vegetations grow on the heart valve, usually the heart valves, sometimes on the other bits of the endocardium. And those vegetations could spread so that they would destroy the valves. And those vegetations could spread so that they would destroy the corda tendanie operating those valves and therefore produce more valve disease. So now we're going to talk to you about the risk groups. And that's important to you, isn't it? Did you make a mistake? Is Mrs. Horn suffering right now because of your mistake? And when I talk to you about the risk groups, I'm going to talk to you about the risk groups prior to the NICE guidelines in 2008. And then I'm going to talk to you about the risk groups after the NICE guidelines. And then you can see there hasn't been much change. So let's talk about the risk groups prior to the NICE guidelines, prior to 2008. And I'm going to put them in 6 categories, 6 groups. And the first ones were acquired valvular disease of the heart with incompetence and stenosis and regurgitation. Well, you say to yourself, what's that mean to us? We're just dentists, dental therapists, dental hygienists. What's all that? Well, there are 4 valves in the heart that you know of. The mitral and the aortic, which sit on the left, and the tricuspid and the pulmonary, which sit on the right. The mitral and the aortic, which sit very closely together. They are desperately important to you and me and you. Why? Because it is these that are mainly and mostly affected by valvular disease of the heart. And when valves become diseased, what happens to them? They either become smaller, and we call that a stenotic, or they become bigger, and we call that incompetent. And some valves can become stenotic and incompetent at the same time. So that aortic stenosis and aortic incompetence, mitral stenosis and mitral incompetence, tricuspid stenosis and tricuspid incompetence, pulmonary stenosis and pulmonary incompetence. And the combination of these were previously, prior to the NICE guidelines, a risk and had to be put on prophylactic antibiotics. The second group you see up there is patients with previous history of infective endocarditis. So whether they've had infective endocarditis 2 weeks ago, 2 months ago, 2 years ago, whenever, they were increased risk and had to be put on prophylactic antibiotics. The third group you see up there are patients with artificial valves. So whether it is the pig's valve from the local sausage people, whether it is the Cajun bowl, whether it is the tilting disc, whatever. And there is a significant risk in patients with artificial valves. The fourth group were the congenital heart diseases. Patients with an auricular septal defect, patients with a ventricular septal defect, patients with a patent ductus arteriosus. These patients were considered risk not because they had valve disease, but for example, in a ventricular septal defect, where that ventricular jet of blood impinged under high pressure on the opposite side of the heart, that's where it was thought injury could start and infection could start, but not on the valves. So that is group number 4. The fifth group were the rheumatological patients, patients with acute rheumatism or acute rheumatic fever. You know, acute rheumatic fever is where you have a sore throat, and 2 weeks later, you go down with pains in your joints. Rheumatism, and it was due to a bacteria, the beta hemolytic streptococcus of Lawrenceville group A. And because the bacteria shared the same antigen in the heart, an immune reaction was set up and antibodies were diverted towards the heart. And acute rheumatic chorea, where there is a disease of the central nervous system. The mother wonders why the patients can't sit still, why the kid cannot sit still. They have a lesion in the basal ganglia. But that is another phenomenon of acute rheumatism as acute rheumatic fever is. And the last group, number 6, are patients with intravenous drug abusers, because they inject things in their veins, smack, methadone, and whatever it is, I don't know what it is, but they don't have a cross-infection policy. They share needles. So these are the 6 groups previously. Now the NICE guidelines came along. The Department of Health instructed the National Institute of Clinical Excellence in 2008 to produce a report of who is a specific risk or an increased risk for infective endocarditis. And the NICE report specifically puts down 5 groups of patients. Now there is some confusion, that is some practitioners, some dentists, some dental therapists, hygienists, they say we are confused because the NICE guidelines have changed anything. Well, let's see if they have. Well, what do the NICE guidelines say? The first thing is, the NICE guidelines say health practitioners, that is you and me and you, should regard the following patients as an increased risk of infective endocarditis with the following cardiac conditions. And what is the first thing they put there? Acquired valvular disease of the heart with stenosis and regurgitation. So nothing is changed. Aortic incompetence and aortic stenosis, mitral stenosis and mitral incompetence, tricuspid stenosis and tricuspid incompetence, pulmonary stenosis and pulmonary incompetence, or the combination of these are still an increased risk and ought to be put on prophylactic antibiotics. The NICE guidelines hasn't changed anything. That is, patients won't come up and say to you, I have acquired valvular disease of the heart with mitral valve stenosis. But they will come up to you and say, I have a leaky valve. Nothing's changed. The second thing the NICE guidelines say, what does the NICE guidelines say? The NICE guidelines say previous history of patients with infective endocarditis. As previously. So the NICE guidelines hasn't changed anything. The third thing the NICE guidelines say is patients with artificial valve. Whether it's from the local sausage people, the pig's valve, whether it is the Cajun bowl, whether it is the tilting disc, whatever the kind of valve it is, they are a significant risk. And the NICE guidelines specifically say that. So up to now, the NICE guidelines hasn't changed anything. What is the fourth thing the NICE guidelines say? The NICE guidelines say congenital heart diseases with structural defects, other than a closed, a fully closure VSD and a fully closure PTA? Well, that was obvious. Previously, if we had a patient which didn't have a closed VSD, we would have put them on antibiotics, and if they had a closed VSD, we wouldn't have. Now, in a ventricular septal defect, as I said, there is no valvular lesion, but where that ventricular jet of blood impinges on the opposite side of the heart, that's where it's thought that injury could start and infections could start there, and nothing has changed. The NICE guidelines also say that patients with hypertrophic cardiomyopathy also need to be put on prophylactic antibiotics. So you say to yourself, what's all that mean to me? Well, cardiomyopathy just means muscle disease. And patients with a hypertrophic cardiomyopathy means they have bigger cardiac cells, which is causing structural defect in the structure of the muscle, the myocardium. And so it turns out that a patient comes up to you and say, I have an artificial valve. I have had previous history of infective endocarditis. I have acquired valvular disease of the heart. Then you mustn't do anything to them. I suppose you can just look in their mouth, but you really mustn't do anything to them until they've had prophylactic antibiotics. So now, let's talk a little bit about the symptoms of patients with infective endocarditis. Because Mrs. Horn is sitting at home at the moment. You want to know what the symptoms are. Now, the symptoms of this illness are pretty much vague. Patients just feel vaguely unwell. They can't put their finger on it. It's non-specific. They can't eat their food. They're lethargic. They're not feeling well. And if you know someone has a heart valve lesion and they've recently had an endoscopy or a urethral manipulation or had a root canal treatment, and 5 days later they're in bed, they're not feeling well, you should at the very least suspect there's illness. The next thing you see up there is the physical signs. You want to know about the physical signs because you don't want, as I said, you don't want anything to happen to Mrs. Hall. You want to see what you would see in patients with infective endocarditis. And the very first thing you would see is a big heart. And if you had a chest x-ray and you could look at it, you would notice that the heart is bigger. Because the heart can hypertrophy. Because the valve is leaking, the heart has to work harder, and so it gets bigger. The second thing is, there may be a cardiac lesion, and indeed there is. There is a valve lesion. And if you had a stethoscope, and you could listen to it, you would hear murmurs. Murmurs mean valve disease. Murmurs do not mean hypertension. Murmurs do not mean coronary artery disease. Murmurs mean valve disease. Now, it is quite characteristic of the murmurs of infective endocarditis that they change from day to day. Instead of staying constant, as they would with an uncomplicated mitral stenosis, that's reasonable. Here we have a destructive process around these valves, altering the turbulence around these valves. So the murmurs are often different in character and intensity from day to day. An interesting thing develops in the fingers, which we call clubbing. Have you come across that? Well, if you remember, I was telling you that when I was talking to you about congenital heart disease, and I told you that there are two cardiac lesions which produce clubbing. One of them is any form of cyanotic heart disease, whether it's tetralogy of Fallot, whether it's transposition of great vessels, whether it's tricuspid atresia. The second one is infective endocarditis. a condition in which there is expansion of the distal compartment of the fingers. So if you held them sideways, you lose the angle between the nail, which is this thing here, and the nail bed, which is the thing behind it. There is normally an obtuse angle. That gets flattened out, and there is soft tissue expansion. So that the end of the finger looks like the end of a chopstick. If you were to examine the abdomen, you will notice there is a structure in the upper left abdomen called the spleen, which is often not palpable. But in many septic conditions, it becomes enlarged, in fact, in many other conditions as well. And splenomegaly is a possibility, a big spleen. The kidneys may be involved in this disease because, as I said to you, there are emboli shot into the peripheral circulation. So the kidneys may have multiple infarcts in it. And so the patient's urine may be abnormal underneath the microscope. There may be blood, there may be protein, there may be other things. But the kidneys themselves are not enlarged, are abnormal to feel, etc. And then these spots all over the place, they represent the appearance of small emboli in blood vessels. So small petechial hemorrhages, sometimes even painful ulcers, sometimes painful spots at the tips of the fingers, they're all found. They all have various names like Janeway nodes and Osler nodes. That's not important. As long as you remember, they represent and their appearance of small emboli in blood vessels. And if you took the patient's urine, they would be abnormal. And if you took the patient's temperature, they may have a bit of a fever. So those are the physical signs you will see in patients with infective endocarditis. A big heart, 1 or 2 murmurs, finger clubbing, abnormal urine, abnormal lesions in skin due to small emboli, and fever. Having done all that, and you've seen all this, you want to diagnose this illness quick. So I'm going to now talk to you a little bit about the diagnosis. How do you diagnose this? And why is it important to diagnose this? Well, there are 2 things you can do. Absolute proof depends on getting an organism from the bloodstream. So under sterile condition, you take blood, ordinary blood, venous blood from the venous circulation, and you send it for culture. And you do as many of those as possible, because it's quite likely that they will not all contain bacteria. And the idea of the exercise is to get a rapid, accurate diagnosis. So you know the sensitivity of the organism and whether it is or not sensitive to antibiotics. And that information must be got quick. So multiple blood cultures are done under sterile conditions. So you prep the skin, you scrub up as if it's a fully sterile procedure, etc. And as I said, the idea of exercise is to get a rapid, accurate diagnosis. Enough said. The second thing you can do is to actually send a patient for an ultrasonic scan of the heart. Then you can actually see those vegetations growing around the heart valve, damaging those valves, nibbling away at those valves. But getting the blood culture is much more important than an endoscopy. Together, they're invaluable. Now, this is a very important disease, and it can be prevented. Now, having diagnosed this illness, what would happen if you do not make a diagnosis? Well, Mrs. Horn could actually die because she can actually rupture her cardiac valves because the inflammatory process is vigorous enough to do so. It's not a very good idea to rupture your cardiac valves because you would die, or at the very best, you would go into very severe and serious heart failure. Thirdly, it's not a very good idea to have infective endocarditis because you may have a fatal emboli to the central nervous system, to the brain. So those are the reasons why it's important to make the diagnosis quickly. Now, as I said to you before, it is quite characteristic, isn't it, of the murmurs of infective endocarditis, that they change from day to day. As I said, instead of staying constant as it would with the uncomplicated mitral stenosis, here we have a destructive process around those valves, altering the turbulence around those valves. So the murmurs are often different in character and intensity from day to day. So now you've diagnosed Mrs. Horn with this illness. How would you treat this? Well, that's fairly obvious. If you know the sensitivity of the organism, you give them massive doses of antibiotics, usually by intravenous infusion. What kind of antibiotics? Well, if you're dealing with the ones that is found in 3/4 of the cases, in the vast majority of the cases, is penicillin. And you may give them 2 mega units of penicillin 4 hourly for that organism. And sometimes you give them an introductory dosage of gentamicin as well. So massive doses of antibiotics by intravenous infusion, 4 hourly, extending for 4 to 6 weeks. So it's quite a tall order. And that's a very important disease. And it's a very serious disease, and it can be prevented. And I'm now going to talk to you about what you should do as budding dentists, as dental therapists, when you know you have a risk patient in light of the NICE guidelines. Patient will come up and say to you, I have acquired valvular disease of the heart. I have valve disease with stenosis or incompetence, or I've had previous history of infective endocarditis, or I've had a valve replacement, or I have hypertrophic cardiomyopathy. Then you mustn't do anything to them. Well, you can just about look in their mouth, but you mustn't really touch anything till they have had prophylactic antibiotics. And if you're doing something on the local, you give them 3 grams of amoxicillin, which is a broad-acting penicillin. And if they're allergic to penicillin, you better ask them if they are, because you don't want them to die of the disease rather than the treatment. You give them 1.5 grams of erythromycin. These are big doses and is enough to prevent them getting endocarditis. And if you're doing something under general anesthetic, you better have that patient in hospital, and you give them combination of vancomycin or gentamicin and amoxicillin, and if they're allergic to penicillin, they get vancomycin and gentamicin. You need not bother writing all the doses or remembering the doses, but this is the basis of your treatment, prophylactic treatment to stop them getting endocarditis. Now the dentist, that's you and me, have a role to play in patients with known infective endocarditis. That is, if the source of the infection is not known, so for example, it hasn't followed an endoscopy or going to a chiropractor or having a urethral manipulation, it could be that they are dealing, or you're dealing with an infected retained root. So dental treatment of patients with infective endocarditis is a routine once you've identified the septus. That is all I have to say to you about infective endocarditis. And I cannot stress to you more than I have already the importance to you. Patients, there is somebody who's bound to walk into your dental practice and say, I have valvular disease of the heart. Somebody is bound to come in and say, I've had a valve replacement. And if you don't know about this illness, it's a disease which can haunt you for the rest of your life. Now suppose the patient does not respond to antibiotics. Is there anything else you can do? Well, your treatment, of course, is carried out with close consultation with the cardiac surgeon. And if the patient is not feeling good and is going into heart failure and is not recovering, they have an acute emergency valve replacement or replacements, and you're expert on valve replacements. Following my talk to you about valvular disease of the heart, and that is the only way they can stop the dental sepsis. Finally, I want to talk to you about some of these rare organisms other than bacteria which can cause this illness. For example, there is a thing called Q fever. It comes from cattle. Q stands for Queensland and is due to a thing called Coxiella burnetii, and it accounts for a very small percentage of cases. And as you know, it's extremely difficult to treat. Chlamydia psittaci or psittacosis is a disease of the birds. And again, this organism can sit on damaged valves and cause an endocarditis. Again, non-bacterial and very difficult to treat. Candida albicans or ordinary thrush can get into the circulation. Patients are immunocompromised, for example, in AIDS patients or patients on cytotoxic therapy, and cause a very, very serious form of endocarditis. Aspergillus and histoplasmosis, again, these are fungi which again are normally not a problem. They can cause a very serious form of endocarditis. What I'm saying to you is, if you get a negative bacterial culture, you say to yourself, maybe I'm not wrong with my diagnosis, maybe my gut feeling isn't wrong, but I'm dealing with one of these rare organisms. And I've got to alter the culture medium and know that they are not going to work with therapy and they need a valve replacement or something like that. I hope it's been useful. That's all I know about infective endocarditis. And thanks for listening.